Ready? Okay, I'm going to call the meeting to order. Welcome to the Behavioral Health Board meeting in West Sacramento. Glad all of you made it. Chris ended up in Woodland. So he's going to be a bit late, maybe some other people too. I knew this was going to happen. We're just so used to going to Woodland. Who is? Maria. Okay. All right, so we are going to start off with public comment. I'll look at anyone here. Would you like to make a public comment? Please, go ahead.
Just talk from here?
Or however you stand up, or you can sit,
Okay.
or whatever you want.
We'll join at the table.
Sure.
So my name is Allison Rodriguez. I'm the director of our behavioral health youth and family programs at Community Care Lake. Thanks for having me here. Right? So Community Care Lake is a federally qualified health center, a nonprofit community health center dedicated to providing comprehensive medical, dental, behavioral health, and substance use services to families across Yolo, Napa, and Solano counties since 1972. In Yolo County, we are one of the primary providers for mental health and substance use treatment. As part of our commitment to community wellness, we proudly partner with Yolo County Health and Human Services Agency to serve Medi-Cal and uninsured community members, and we have partnered with the county on service delivery for over 35 years. We provide several programs for the county, and one of our key programs funded by MHSA is the K-12 partnership program that is being discussed today. Through this funding, we provide school-based mental health services in the Davis Joint Unified School District and the Yolo County Office of Education. These collaborations allow us to offer critical mental health support directly on school campuses, where students spend the majority of their time and where early intervention can be most effective. Our services include individual counseling, family and caregiver sessions, child psychiatry, case management, to ensure students and their families are connected to the broader network of community resources. We've witnessed firsthand how accessible school-based mental health care can transform the lives of young people navigating complex emotional, social, and academic challenges. By meeting students where they are, we reduce barriers to care such as transportation, stigma, and scheduling conflicts, barriers that often prevent families from receiving support or care at all. Through our K-12 partnerships, we have served over 500 students. Students, families, and school staff report visible improvements in these students' behavioral and mental health. For example, an elementary student at risk of expulsion experienced a decrease in disruptive behaviors, was able to stay in school. A middle school student separated from her primary parent was able to process her experience, strengthen her personal identity, and make plans for her future. A high school student with labile moods who was struggling with academics received an early diagnosis of bipolar II disorder and was able to access therapy and psychiatry, ultimately graduating high school and attending her first choice university. These are just a few examples within the hundreds we have positively impacted. It's estimated that over 70% of all mental health services received by youth in the United States are provided within schools. Children and adolescents are much more likely to initiate and continue mental health care in school and in other community settings. This is the way to reach and serve youth. By embedding mental health professionals within school communities, we not only support individual students, but also contribute to a healthier, more resilient school environment. Our work is a testament to the power of integrated care and the importance of sustained investment in youth mental health services. To discuss funding and potential cuts, it is crucial for everyone to understand the details of these services and the impact that they were no longer provided. Thank you.
Thank you.
Thank you.
Any other public comments? There'll be more opportunities. Any public comments from people online? Okay, we'll move to approval of the agenda. I'll entertain a motion to approve the agenda.
Motion.
Okay, Stephanie, second.
Second.
Right, Melanie. All in favor, say aye.
Aye.
Opposed? Abstentions? Okay, the motion passes. Approval of the minutes from the May meeting. Big motion on approving the minutes unless anyone has any changes and want to make.
Emotions.
Emotions. Second?
I will second.
Melanie seconds again. All in favor, say aye.
Aye.
Opposed? Abstentions?
I abstain.
Okay, we have abstained from Moises. Okay, member announcements. Any member announcements? Okay, chair report. I want to introduce our newest member from District 1. And thank you to Supervisor Villegas for making that appointment. You had a long walk, right?
Yeah.
Meg, Sue, and I had the opportunity to meet with for about 45 minutes before this meeting. We enjoyed our meeting with you, so thanks for coming out and coming out early. Would you like to introduce yourself, please, Mrs.?
Good evening, everyone. My name is Moises Diaz. I am a newer resident here to District 1. I'm excited to be here representing at least my part of the district. I am a consumer of mental health services here in the county. I also work for Congressman Mike Thompson, so I'm just going to put that out there on the table. But I'm looking forward to getting to work, especially. Thanks for having me.
All right, and we're very thankful to have you. Thank you. Any correspondence?
None.
None. Okay, we're up to the mental health director's report, and Moises, what we do here, do you have a packet?
I do,
So if
yes.
you turn to what, 6, 7 pages in, you'll see the mental health director's report. And this was prepared by Tony, our mental health director. And what we do is we ask for board members to pull items, those that you're interested in, that you have questions on. And generally, once you pull the item and Tony's going, he'll say, you know, what questions do you have? So any agenda items that our board members want to pull.
D, innovation.
D. Want to pull B, MHSA. Anything else? Sometimes our Tony will wants to present on some items that aren't even pulled or items.
Okay.
Why do you laugh, Tony?
Okay.
I'm gonna do H. Is there anything else? Yeah, I got you.
Is there a preference for me to go in order, or
Yes.
I have a feeling D may be a longer conversation?
Yeah.
You know, want to say that the last maybe?
Sure.
Okay.
Is there anything you wanted to present on first?
I would just make notice of the fact that our new agency director, Monica Morales, started today. Today was her first day.
Oh, good.
And so Joan Flannel, who's been our interim director, is going to continue in a consultation role for a few weeks while Monica makes her transition in. For those of you who weren't here last time, Monica Morales is coming to us from Santa Cruz, and she was the previous director of their health department, which included their public health branch and behavioral health, and I think they had environmental health. They had a couple of different types of things set up a little differently than we have here. So we're welcoming her here as of today. I'm going to go to D, to Mental Health Services Act Innovation Plan. So where we're at currently is that the Board of Supervisors had approved the plan, and it was on the Behavioral Health Oversight and Accountability Commission's agenda on May 22nd. It was on their consent agenda, so it passed through with no problems. There are still some internal things that need to happen if we're going, and I will say if we are going to move forward with you implementing the plan, right? If you recall, part of this was like we had to come up with a plan quickly so that we didn't revert the $478,000. And now there's some things that we need to deal with in terms of making sure that we have all our I's dotted and T's crossed with regards to procurement stuff, right? So there previously been some contact that had happened with CalMesa about the Smart Care electronic health record about a year ago, and we're just now we're just making sure that we have everything straightened out where there wouldn't be a challenge to us moving forward with it.
Okay, my question for you is going to be about the timeline, but it sounds like it's too early to ask that.
A little too early, right?
Okay.
Yeah, I figured you were gonna ask, like, when's this gonna happen? Yeah, so there's just, there's some internal review that'll be happening, and, I can report back on that next one.
Okay.
Even though it didn't get pulled, I'll just comment on the fact, that the request for proposal for the mobile crisis response has, the deadline for submitting proposals has passed. I know that there was some interest in having a member of the Behavioral Health Board on the selection committee, but it sounded like, when I was talking to the individual who was kind of interested, it wasn't really sure. So I'm gonna put it out there. We need to start scoring the proposals to select a vendor. And so if someone from the Behavioral Health Board would like to participate, please let me know and we can set that up. You'd like to. Okay. I think we only need one, so we'll have a,
Melanie?
okay. If we have a second, then we'll come. Okay, we just need an odd number, so we have two people internally, right? You know, so we try to have an odd number. Okay, H, the adult full service partnership update. Last time I was here, we were disclosing that our contracted partner, Hope Cooperative, has chosen not to extend their contract. So their contract currently terminates on June 30th. And that which is well within, you know, their right not to extend the contract. We still value them as a partner. It's just they're moving on from Yolo County, right? So just to make sure that I'm dispelling any rumors that may be out there, you know, this is not something that we did not cut the contract with them. They chose to terminate the contract. There was also a rumor that was going around out there that we were not paying them, and that's also not accurate. You know, we are paying them for any invoices that they submitted to us, and we value them as a partner, and we're not gonna stiff them. We've had to quickly get things put together in order to try to stand up a full service partnership program internally. As I reported last time, there are currently 207 clients who are receiving full service partnership services. We're going to be able to stand up an internal program that will be able to provide full service partnership services to 100 of those clients. We will still serve all 207 clients or ensure that they get connected to services. And so we're evaluating each client on a case-by-case basis, as well as clients that we're currently serving. We are working with some of our partners, including Communicare Olay, right? With regards to individuals that may be ready to step down to a lower level. And I will call out Communicare Olay because they generously offered and advised that they had some capacity and thought that they could help us out because they were aware of what was happening here. And so we genuinely appreciate that. So we are in the process of hiring for the FSP program. The idea is to have a 10-to-1 ratio. There were interviews being conducted yesterday and today and last week, and we believe that we'll be able to staff up that program prior to June 30th. We're doing internal recruitments, which means that we are robbing from Peter to pay Paul, right? And so we're going to have to navigate through that because we may be impacting some programs, including our child welfare services team. Our case managers from the housing and homeless team and our wellness centers have been providing on-site support for FSP clients at both Mercy housing sites and tiny homes. We're working to assign all incoming clients to case managers so that each person at least has one primary point of contact for things that are coming up. 64% of clients who receive their medication through injection have scheduled their medical and psychiatry appointments, and 100% of our existing assessments have been reviewed to determine if a reassessment is required. So of the 207 clients, we need to do 72 reassessments, and we scheduled 35% of these appointments already. So it's pretty ambitious to try to take on this many clients in this short a time frame, but I have a dedicated team who is really working very hard to make sure that no one slips through the cracks. Last night, we held a town hall meeting, which was virtual. Invited current clients of the program and the community to come and to receive an update like the one I just provided you. Provided an opportunity for clients to discuss how this may impact them, and also for the community to ask questions and have them answered. And a lot of the concerns were for clients not knowing sort of the uncertainty of what was going to happen. Am I going to go continue with my full service partnership services, or am I going to have a lower level of care? There were concerns from clients about whether or not they would be able to continue to receive transportation benefits or assistance with paying the rent. Some clients were worried about situations that have come up historically where they may be out of money and they need some tangible supports like groceries and things like that, right? Which are benefits of a full service partnership program. And what I'm communicating to the community and to the individuals that are affected is that we're evaluating on a case-by-case basis. We're just simply not able to provide full service partnership services to all 200 clients, but we're going to evaluate it on a case-by-case basis. And then we're going to move in a fashion so as it's my intent and my commitment not to have someone end up homeless because of this, right? That's contrary to what we're trying to do as a behavioral health plan. I don't have the specifics though, right? So those are still things that we're working out. And my intent is to continue to have these town hall meetings. And I just need to figure out what the right cadence is, what the right frequency is. I don't want to have one and then the next day say, well, I don't know any more than I did yesterday, right? But I don't want to have them so far out that people are wondering what's going on. But we are confident that we will be able to care for all 207 clients on July 1. It's just, we're going to be stretched pretty thin as a system of care in doing so.
And I listened to that town hall, and one of the things that I thought was very interesting and positive in some respects is that it seemed to me like most of the people who were asking questions were consumers.
Correct.
Which usually doesn't seem to be the case, like they can, and it was nice because you gave them anonymity, which was really nice. So that was great. But I was wondering, do you feel like you did a good job? Because I was surprised there weren't more family members or advocates that were having some questions. Do you feel like you did a good job in sort of marketing it? And was NAMI involved in sending something out? Because that's, so Jen is saying no, and so I mean, to me, like that's your bet for your next meeting. That's your best resource to get information out, and normally they're the ones that you're going to hear often making comments.
I can certainly appreciate that feedback, and it is well received, right? And so I'm willing to take any good recommendations that you have about how to better market like a future town hall meeting, right? I mean, we do want to make sure that people that are being impacted and people are impacted not just because they're clients, like you said, there's family members and loved ones, right, who are impacted by this decision. And we want to reach anyone that wants to participate. So I agree with you that I was anticipating that there may be more people that were there that were, I want to say there was maybe like, we estimate like 25 people, right? 25 to 30 people, yeah. And we have 207 clients, right? So part of it was, we knew there were going to be some challenges no matter what we did, right? Because some individuals may have difficulty with access in a virtual format, or it just may be unfamiliar to them. We did think about doing it in person, but then we ran into potential logistical challenges with like transportation and how to do it. Also, I have some concerns about people being able to be anonymous and being able to really provide sincere, right, feedback that they may, or that there may be like some of a stigma that's attached that may be a chilling factor for that. So ultimately, we did decide to go with a virtual format to try to account for all those variables, but we can do a better job next time of making sure that NAMI is involved and that maybe other advocacy systems or different programs that are like have cross sector contact with our clients are made aware of that.
Did you, I know when Chris and I were working in the mental health court, a lot of the participants were trying to get into the full service partnership and there were waiting lists. And what we found is that Hope Cooperative had people still listed on there, however many numbers they had, that were had been off the grid for quite a while, you know, like not reachable. So they weren't being served because unfortunately they couldn't find them, but yet they were still taking up the space. Have you found, or are you there yet, that out of those 207, there's a good number that aren't getting services because they're off the grid?
I can't speak to that specifically, but I believe that there were, I know what you're talking about, and are you talking about the prior contractor, not Hope Cooperative, but
That would be Hope Cooperative. It was people that were referred and then either couldn't find them or they were rejecting services, remaining homeless and opting to do that as opposed to engaging in the services.
we do believe that of the 207 clients, that there were some individuals that were part of the roster, right, who were not actually, had already been discharged for services, but it hadn't occurred on paper. But we want to make sure, you know, and I can't speak to the degree with which that's a factor, but I'm not hearing from staff that it's like this significant thing.
Any other questions? Oh, well, hey, we're going to get to public comment in a minute, Emily. Go ahead. Hold on one sec.
I'm actually here representing Supervisor Ferricks.
Oh, I'm sorry.
That's okay. So I just wanted to say that he has a newsletter that he'd like to promote those kinds of activities like the town hall. So I just wanted to interject with that.
Okay.
That would be a good way to get it out. Anyway.
And I'm sorry, I knew you were working with Supervisor Ferricks. I apologize.
That's okay. No worries.
I saw you shake your head when I said that. You gave this little shake. Nope. Okay. All right. So, and then Chris, do you want to, we pulled B, D, J, and H. And you don't have to tell me right now, but if there's anything beyond B, D, J, and H you would like to pull, let me know. Aye.
I
Okay.
have a question on that.
Okay, so let's go to I.
Okay. So Yolo County as a community, the district attorney's office, the public defender, probation, and health and human services are intending to file to apply for the Board of State Community Corrections Proposition 47 Cohort 5 grant. So in one way, shape, or form, one of the agencies has received each one of the rounds of grants. So 1 through 4, we've already received, whether it's like probation or health and human services. And so the focus on this grant is to provide opportunities for individuals to receive services when there's issues that are related to substance abuse, right? And essentially, this is going to be a way for us to fund Proposition 36 cases, right? So individuals who are charged with BC 11395, a number I've never thought I would have memorized like that, but here we go, right? And we're still there, you know, I was just on a meeting earlier today, we're still navigating through some of the philosophical differences about how to approach it, but ultimately we want to create a vehicle to ensure that we're able to serve those clients that are those defendants who may be eligible for the mandated treatment types of services that are prescribed under that penal code. Additionally, what we want to do in applying for the grant is to identify the collaborative work that has been done over the past 10 years between the partnered agencies to stand up the other treatment courts, right, and diversion courts as a way of demonstrating that these 4 agencies can partner well together, right, with a long-term intent of seeing if there is not a way to ensure that the other courts that have already been established, aren't eliminated, right? So when the when Prop 36 came into effect, we were having some local challenges with implementation, just because there was no funding attached to it, right? And as you may recall, the district attorney made a decision to halt some of the referral of cases to the other specialty courts, right? In an attempt to prioritize Prop 36 cases. And so my hope as the behavioral health director is that we're able to put together some sort of a new type of infrastructure that may be similar to like a multidisciplinary team or something like that, where individuals that may be eligible for one or more of these types of courts would be able to be reviewed and kind of directed to the proper court. So this is a great opportunity. It would be $8 million over the course of 3 years, from January 1, 2026 to December 30, 2020. There's going to be stakeholder engagement opportunities. You may recall that Chris and I did a presentation last time, and you can see in here where there's some different opportunities for individuals from the community to come and learn more about what we're trying to do and to provide input on June 3rd, June 9th, the 11th, and the 16th.
Well, my question is, with that funding, how many people at any one time will you be able to provide services to? We have a certain number of FSP slots.
Yeah,
There's the same issue with these programs as to how many people you can provide services to. And concerns that there may or may not be enough for the target population, if that's even a viable target population. But just
you mean that we may have too much money and not enough clients, or the other way around?
I don't know which way it's going to go.
So I think that's what we're asking the same questions, right?
But as
So
far as you're doing your budget, how many people can you provide services to?
That we're not sure yet, right? So the district attorney's office is telling us to anticipate that somewhere in the neighborhood of about 150 people a year, right? That's what they are thinking is a logical estimate, right? But we haven't done the math yet, and part of it is we're trying to anticipate what costs are going to be and how many people we're going to be providing services to without fully knowing yet, right? But the number 150 keeps getting thrown around out there, right? And I don't know if that means that we could serve 150 people at the same time, but 150 people over the course of a year.
I don't think you can do 150 with this funding.
I find it hard to believe that we could, right? I think that one of the other things that we're trying to kind of wrap our minds around is what if there is not quite the demand that we think there will be, right? And so we want to, in developing the grant proposal, we want to try to build in a little bit of flexibility, right? If it's allowable, that if we have money that's left, right, that we could potentially try to use it to support other needs for dependents who have behavioral health issues.
Is there a housing component?
Well, Prop 36 requires that, right? And so we were in a conversation today, right? And again, we're trying to speculate, like if we had 150 people a year who needed housing because of this, we would be very challenged to meet that level of demand, right? But ultimately, there's going to have to be some element of housing because it's a required element of the.
But the housing element isn't housing. It's treatment housing. I mean, so it's not if someone doesn't test on the ASAM for residential, but they're homeless. I don't think the grant is. The funding for that person to be housed would not come from the grant. I don't think it would, or the treatment would come from other areas under your auspices. So when you say, because one of the things that we talk a lot about is because there was a lot of talk about, how much it's gonna cost for housing, when in fact, a lot of the experts, opined that, you know, it wouldn't be that high a percent that would test high enough to need housing. It might be intensive outpatient or outpatient. So when you say housing, you're talking residential treatment, right?
I'm gonna be honest with you, in the conversation that was happening today, and again, we're still fleshing out some of the details, right? There was conversation about, a concern that if we had to provide housing, right, like housing, that we would likely not have enough funding and that there wouldn't be enough local resources to meet that kind of demand, either,
The
right?
statute doesn't
Yeah.
require
Yeah.
housing.
Yeah, so,
All right,
Yeah, just for connections to care, I believe it was capped at 40 people, so I just, looking at this,
there has not yet been any kind of a determination about how many slots there will be.
I can tell you, that the challenges, people are facing are the same that we're seeing in almost every county statewide.
Mhm.
I was talking to Santa Clara, a huge, large county, and they had only so far one person that had agreed to the end of the program. You guys have, I saw the report, they like 13 or something.
My understanding from the conversation earlier today was we have 8.
Okay, that was something
It
different.
went down, then didn't.
So, I mean, I will wait and see if I have a fact checker who will. Because they're getting some feedback and other things, but yes, like earlier today, it came up in the conversation we were having about this meeting that we have 8 individuals in treatment right now through Prop 36.
I thought I was watching the board of supervisors yesterday and I thought on the report, maybe I'm mistaken, probably said something like 30, because I was surprised that the numbers were pretty high compared to like a county like Santa Clara. You know, but it could be 8. But I thought I heard, anyway,
But I'm not gonna say that 8 with authority,
yeah,
right?
that's
Okay.
fine. Any other questions?
I was, let's say, somewhere between 8 and 13.
Okay,
Okay.
deal. Any other questions? All right, let's go to, Jay.
Jay, okay, so we kind of arrived at crisis. I don't want to call it crisis now 3.0, it was crisis now 2.0, and we just pivoted to this pilot approach. What we've received permission from our procurement department to do a sole source with the well space crisis receiving behavioral health program in downtown Sacramento. And so we're in the process of working through development of a contract. We're also modifying our existing contract with Safe Harbor to allow us to hold some additional beds that will be slated for more of a short-term use, right? And they're still kind of working with their licensing just to make sure that it's not going to be problematic, but we've agreed in principle and we're starting to work on the contract stuff. So the target date is July 1. It's a target date. I don't know if we're going to get there or not, right? It'll depend on how quickly we're able to get everybody's lawyers to agree on things and then get it before the board, right? But at some point here, I would say during the summer, we'll have some sort of system in place where an individual who would be able to benefit from the behavioral health receiving center could go to one of those facilities.
Question,
Yes.
the mental health triage protocol, I think, that came in. I was just looking, it's effective June 1, the revised, finance icon.
Which what are you referring to
Yeah,
specifically?
so it's a, for the fire, so it's a protocol that they can, the mental health protocol, so it looks like they're trying to make it so that it's easier for folks who are, people are calling because they think they're in a mental health crisis, so they can actually they can physically clear them,
Mhm.
and they can then hand off to the mobile crisis or to a mobile crisis,
Mhm.
or take them do what sounds like a chair, because they're not gonna be 5150, they're gonna be medically cleared. And I'm just curious if we're factoring in that that might increase, because we're looking at 7 chairs before, maybe there's more now, but.
Yeah, I think even whatever Crisis Now 2.0 is going to be, right? There's my guess is going to be if we have a fully functioning mobile crisis response team and perfect coordination between all of the different partners, including fire and law enforcement and the local community, right? That there's likely more demand than we would have, right? And so I would anticipate that what we'll have is essentially 6, right? But I think there may be a little bit of flexibility with the safe harbor site, right? Although we're going to be limited at that site to Medi-Cal beneficiaries. At the other site, it's not an issue about what type of insurance. But I believe that you're probably right that that there is likely going to be more demand than we have chairs available.
Was there a way, would it be appropriate to have a presentation on how this is going to be coordinated to make sure that there's not a silo with YMSA doing this and then, you know,
You're saying YMSA?
well, yeah, YOLO Emergency Services.
Okay,
that's mine.
okay. The other
Mine.
emergency service.
Yeah, YOLO County Emergency Medical Services Agency. So I just, I mean, it sounds like it could potentially have a positive impact on some of the things we've been talking about and the concerns we have about folks being sent to the ER. And put in instead, so it sounds like this is they're trying to avoid bringing people to the emergency room just even for medical care. With the protocol to allow them to do that. So I'm just curious how this all kind of plays together and what this looks like from the continuum.
So the ultimate goal is to keep people out of the emergency rooms whenever it's possible, right? You know, when we did go and we were able to have a tour of the Well Space Crisis Receiving Center. And what the feedback we received from them is that even though individuals can stay for 23 hours, that their average stay, like kind of the general amount of time that someone stays there is between 10 to 12 hours. You know, generally speaking, someone is coming in, they're in a crisis, and depending on what's going on with them, they may need, you know, just a quiet place to be and something to eat, and maybe take a shower, you know, and get some rest or whatever. And the individuals are generally able to kind of safely leave within 10 to 12 hours. So then it's sort of assuming that that is the case, you kind of have an ability to potentially like double the amount of time. So basically once someone's out, then they have a bed that's available, right? But you know, to your point, I mean, we could, if you think it would be helpful to talk about how we're trying to coordinate it, we can do that. I mean, part of this is that we're working through some of the coordination challenges with just the mobile receiving or other mobile crisis response, right? Because we have 2 different dispatches, right? And every jurisdiction wants to do it a little bit differently, right? And so I not to overuse a phrase like flying a plane while you're building it, right? But there is likely to be an element of that.
Because on the protocol, it does say that if they, you know, meet all of the criteria, meaning that they're medically cleared, then they would get a referral to the mobile crisis. And so again, making sure that if this arm is doing this, that they're calling over here and they're not like, where are you looking? They're like making sure, I'm assuming that everybody's connected the dots, but I'm curious.
We're still working to connect the dots because there's also questions about who determines who goes where, right? You know, and so we have partners with the emergency rooms as well, right? And I think that there's a desire for emergency rooms to say, hey, this person doesn't really come here, they belong over there, right? And so then how would maybe those partners access the receiving center as well, right? You know, how does law enforcement, how does fire do it or EMS, right? Do they need to go through us or can they just bring someone there directly and skip us, right? And is that really the spirit of what we're trying to do either, right? So yeah, we're trying to work some of those details out.
Yeah, because ideally, if people don't have to do it here, it's a lot easier to get them into a crisis chair if they're not in an ER for many different reasons. So I think, yeah, I think it's great I'm just reading protocol, but I don't, there's not a process, there's not structure, it's just a protocol. So I'm not sure how that'll fit. So I was just curious. I was excited to see it.
I'm gonna be honest with you, I'm not familiar with the EPSA protocol, but I'll do some. homework. Thank you.
Any other questions?
Yeah, just to kind of reiterate on your point about potentially at some point making a presentation about the, not great with acronyms, YEPSA. Yeah.
Emergency medical.
There's so many
services.
acronyms here, but anyway, like, I think it would be helpful to get a direct presentation to this board regarding the protocol and regarding kind of how collaboration between different agencies in terms of mobile crisis is going. Because, I think especially in emergency medical services, there's not a lot of transparency towards like people that maybe should be evaluating. So I think that would be very helpful.
Yeah, I mean, this clearly is meant to right care, right time, you can't ERs. I mean, it clearly has it's the medical service arm, right? So they're trying to prevent non-medical service in their mind, even though I consider mental health, part of that continuum, but, so I get it. But, sometimes we see one branch trying to solve a problem, which is great, and it's good intention, but how do we make sure we're not creating other problems? Because we just solved this one, but we need to do it in a coordinated fashion. Yeah, we could get a presentation.
Yeah.
I think that would be.
I'm happy to have someone come in and at least get you up to speed with what we're currently at, right?
Well, especially if you're already doing our pre-remote crisis, it might be.
We are doing
great to have
RP for the
some-
mobile,
have
yeah.
this good impact.
Yeah.
Chair will agenda this for one of the next meetings.
I'll make it to myself. Yeah.
Okay,
I think the one.
oh, I'm sorry.
That's okay. Tony, I noticed in the report, it speaks to how this will be a one-year pilot program that will inform future efforts. This is my first time being involved with the board when we're doing something like this. So I'm just curious to know, will you be reporting out to us to let us know the framework and kind of how this pilot program documenting will take shape and what will be.
I don't think I have a choice. I did a lot of promises were made to the community around Crisis Now and how it would be implemented.
1 sec.
Huh?
Sorry.
Oh.
Siri.
And this was not what was promised, right? And so, I mean, I think that there has to be a measure of accountability, right? Around, okay, well, what are we doing and how is it working, right? I think that there is a pretty strong opinion locally that this is something that is missing from our overall system of care that is needed and that would really impact downstream, right? So the idea is, maybe I'm getting it wrong, upstream, right? But like upstream intervention, right? That could prevent people from being hospitalized and things like that, right? So, yeah, I mean, I'm happy to come back and provide updates and report out about progress we're making. I think long term, we want to find some kind of a solution where we can have these types of a receiving center that's accessible to Yolo County residents, even if it doesn't happen to be in Yolo County, that we want something that is actually going to work for people. Ideally, we would have one in Yolo County, and I think ideally we would probably have 4 of them. We'd probably have one in Woodland, Davis, one in West Sacramento, and one out in the rural areas, right? But I think this is like sort of at least the first step for us to get a foothold, right? And be able to demonstrate that it's working and figure out how to expand from this. I don't know if that answers what you're asking, but.
Yeah, it does. It just was someone that didn't have any knowledge of the crisis now efforts that
Oh, I
the
see.
board has undertaken and understanding that after watching the board of supervisors meeting and kind of hearing the holistic opinions and thoughts about how we fumbled and trying to really stand this up and operationalize it. Now we have a one-shot opportunity to basically build a vehicle in the form of a report that can further justify and bolster why we're gonna go back before the board of supervisors and ask for all this funding. And so I think using this forum of experts to inform your report and further justify why we would want to go back and ask for X.5 million or what have you is going to be critical versus not being involved and then trying to figure out how to help you at that point.
That was a lot more eloquent answer than I gave, so. But I agree with you. Okay. B, so, we are, behind schedule on our Mental Health Service Act annual plan update. We're required to have it completed by June 30th. That's not going to happen. You may recall that when I was here last time, I was explaining some of the budgetary challenges that we're currently having for the next fiscal year with the Mental Health Service Act. And the highlights are that we have approximately $26 million of expenditures, but only $15 million of revenue. We have $11 million of fund balance. That money has to be sort of spent in a certain way, but we think we can move things around, and we could cover all the costs, but then we would completely deplete the fund balance. And then when we arrived at the implementation of the Behavioral Health Service Act, we would also have to carve out some money for housing, and we would not likely have enough funding for all of the services, right? So I presented all of this to the board yesterday, and with the intent of informing the board of the current situation, and asking the board for some guidance around how they would like to prioritize our approach to this, with kind of, generally speaking, sort of three big ideas as options, right? And it's really the board's prerogative to kind of decide how they want to approach it. But from my perspective, we either can exhaust the fund balance and cover all the services that are currently budgeted for, and evaluate the situation throughout the year and kind of figure out what to do next year when next year gets here, or make some selective cuts to programs to preserve some fund balance and to get us prepared for when we arrive next year with likely decreased revenue, or to make like drastic cuts. Now, part of the challenge with like making drastic cuts is that many of the core mental health services that we're required to provide as the behavioral health plan are captured in MHSA, right? And so it's pretty complicated when you start looking at like all of the spreadsheets and all the information that needs to be digested to try to make sense of this, because it's a very complex arrangement. But my best estimate is that even if we said we will cut everything that we're not required to do as a behavioral health plan, right? That we still wouldn't be able to, we would still have a structural deficit in MHSA. And you couldn't do that anyways, right? Because we have some of the elements that are required in MHSA aren't things that we're necessarily required to do as a behavioral health plan. So like a lot of prevention and early intervention work are pieces that have to be done. So what I can tell you is that it is just a very challenging problem to try to solve. And the board has asked for some additional information. I provide you. You're able to see my presentation. They want the board. We've met individually with board prior to the presentation just to kind of get them oriented because of the complexity of it. And they had asked for information about what programs were being funded and at what amounts. And now they're asking for some additional information around what is actually the total cost of the programs, because the information that we're providing them is really only how much of MHSA is funding the programs, but there's additional revenues in some of these programs through Medi-Cal billing or other funding sources. They're also asking for outcome data, and so they want sort of results-based accountability data, and because what I was hearing yesterday was that they would like to consider for any specific program, how many individuals are being served and what kind of outcomes are we getting from those types of programs. So There have been no decisions made about, and I'm reluctant to say the word cuts, right? There's no decisions about cuts. There's no recommendations being made about cuts. We are simply asking the board for some guidance about how to approach it. And we'll defer to the board. We had a tentative timeline of trying to get, we were initially shooting for July 22nd. And then we had to push it back a couple weeks because the board presentation got pushed back. So then we were looking at August. Yesterday, the board was, I don't want to say, I will say signaling, but maybe they weren't, right? But I perceived it, right? That the board was saying, hey, what would be, exactly how late can we be, right? And I reminded them that last year we didn't complete it till December. It creates a lot of challenges the longer we wait, both in terms of the fact that we do need to write new contracts for July, right? And so we're going through that process right now. And so if you're gonna make cuts, now you're spending money, right? So that's one potential issue. The other is that we need to start working on the Behavioral Health Service Act 3-year plan, right? Which is due in March. And I can't start working on that until we get this one sorted out. The Behavioral Health Service Act plan is going to be even more complex because we're not only going to account for BHSA as a funding source, but we're supposed to look at the entire system of care. So all of the funding that behavioral health has in every program, we go through a community engagement process like we do for autism. So all that to say, the board, I think, has a really challenging task in determining what their priorities are and how to approach it. We're going to have a lot of challenges in this. And my intent as the behavioral health director is once we get some clarity about how to proceed with this, that over the course of the next year, to develop a comprehensive standalone behavioral health budget and to make some targeted efforts about generating revenue through Medi-Cal billing where we can, and also to see where there may be some areas where we may be able to maximize some different funding in ways that we haven't, right? I'll pause. If anyone has any questions.
I was just gonna ask, are we gonna be going after any more grants or like innovation grant like we just had this past year? Is that a possibility?
Yeah.
I will say, well, bandwidth is one issue. We're going to have to, I think. I mean, ultimately we're going to try to have to, but I think we're going to have to be very selective. I don't think we can just go after money because it's money, right? I think that we're really going to have to pick and choose which types of grants and which types of funding opportunities make the most sense to us. What I worry about with grants is that the bandwidth issue, but then there's sort of like a lot of administrative costs that get become like that you're taking on, right? And the other part that I worry about is the history of sort of what happens when we use one-time funding. And we stand up services that we can't sustain, right? And I think that we're experiencing the kind of the tail end of that right now, where we have a lot of services that were stood up, and in part with the Mental Health Service Act dollars that we no longer can sustain. So I think the short answer is yes, but the longer answer is it's complicated.
Well, something guaranteed, basically. It's a possibility. It's not a guarantee for future funds.
Yeah.
So one of the things, so I watched the presentation on tape today for the board of supervisors, and one of the things that I noticed in your list for criteria that you also showed to the board, which they commented on, is your not seeing the assessment on measurable results. And I think that I've been our RBAs are 10 times better than they were, 5 or 6 years ago, because we and members of the board of supervisors have been pushing to get RBAs for years and years and years, and they never came until recently. They've gotten better. But I feel strongly that, and I've looked at all that data, and some are performing and some aren't, and for some, the cost per client served and touched is exorbitant, and some not, and some of the grantees write excellent reports and some don't. And having worked with grants for my whole career at the DA's office and managed them, and doing so now, and I spent all day yesterday in a meeting addressing the issue of grants and our budgets. It's really challenging, but I've always had to produce measurable results and lengthy reports, which we haven't required. Almost like we're giving out until recently, like we're giving out money and no one has to say how well they're doing. And so I really feel strongly that should be, and it sounds like the board wants that information too, that should be a really important criteria that you guys should use. And quite frankly, I'd rather not have a mandated program that has crappy results and isn't doing well, and find another program that can do it better than just keep them simply because they're mandated.
Mhm.
So I'm hoping that that's what the board has in mind too, and I'm hoping that you guys consider it. And I don't know if people have comments on that, or if you agree, and if people think it's important that maybe we make a recommendation to the board of supervisors from this body to have, that we feel strongly that HSA should be considering the RBAs when making decisions on how they're gonna allocate or make cuts. So I don't know how you feel about that, or comments, or maybe for you, Tony. But let me just ask what you guys all think.
What are those consequences?
So
I mean, I would
I
say.
think what I don't want to put words in your mouth, Jonathan, but what I hear Jonathan saying is we do have to provide mandatory services, but if we have a partner who's providing a mandatory service and they're not doing well, then why are we still working with them?
Right.
Rather than have someone else provide a mandatory service and we getting more value, right? Along those lines, though, there's potential, fines, sanctions. It really depends on what it is that we're not complying with. And we're not alone. There are other counties that are considering like which mandates may we not comply with, right? We may be willing to tolerate some risk of getting in trouble for something because it's a tolerable level of risk, right? So, yeah, but there is potentially fines and sanctions. And depending on what it is that we're not complying with, it could be bad,
I think what I'm hearing though, you say is that you're like maybe making a motion to require that we look at the effectiveness of those of a particular provider or to move forward with contracts with those particular people. Is that what you're saying?
Yeah, or when the team is assessing, where there might be cuts,
Right.
we would strongly recommend that they consider the RBAs as one of a number of criteria in making those decisions.
Yeah, I would be on board with that. I remember the early days of the MHSA and there were we kind of just moved forward continually without any record of whether or not something was effective and was doing what it was supposed to be doing. And it was frustrating. So I would be on board with recommending.
I guess I'm just not clear on why it would be a recommendation to the board of supervisors, because if we're asking HHSA to do things differently, we just have to do things differently. I mean, why do we need to make?
Because I think the board is giving Tony and each to say some direction. Okay, so I mean, Tony and his team went in there, going along with a plan, knowing full well the board would have issues, and partly because, you know, each board member has different priorities for their districts. And like they thought, you know, the board wasn't completely satisfied with what they were trying to do, which was their best effort. And so I think the decision of Tony and his team was to say, then, you know, help us out here, help give us some direction, and so then we can come back with a recommendation. And so what I felt was missing, and you can see in these 4 criteria, is one of them not being the RBAs. And as Tony said, the board wants more information and has asked for RBAs, so evidently it seems like it's on their radar. And if we're feeling like we're comfortable just saying, hey, Tony, would you consider RBAs? Then as a body, we can leave it alone, or if we want to make a recommendation to the board of supervisors, we can do that too. Either way.
Yeah, so I mean, the only clarification I would provide around this that internally we realized we had a problem, you know, a couple months ago, right? We were like, wait, the math ain't mathing, right? You know, and our priority was really just around making sure that we understood the problems to the best of our ability from a financial perspective. And that's really where our focus has been, just around like, okay, how are we going to make this work with the amount of money that we have and what we have to do. We did consider a couple of potential scenarios, right? And then kind of talking it through with the individual board members, it was like, wait a minute. And the board was like, we just want more information. We want more information, right? You know, and part of it really has been, part of the challenge, honestly, has been developing the language to concisely illustrate the problem, right? And that's taken weeks, right? Because we've had a lot of different internal conversations and it's a lot to process, right? So ultimately, you know, we're giving the board what they requested. The board says we want more information about what exactly is this funding, because if we're going to need to make a decision around making some potential cuts, we really want to make sure that we understand exactly what is being funded and what the costs are associated. To that point, you know, they want additional data points to consider, and it's perfectly appropriate for them to request that. And I think that I would have no problem with this board communicating to the board of supervisors, you know, your own recommendations, right? Because I think that it makes sense to me, at least, that this board is supposed to be kind of I don't want to say neutral, but like an advocate, right? And so I think that it may help communicate to the board that maybe they're on the right track where you guys are sitting, right? But it wouldn't bother me.
And we all know that you have a daunting task.
You know what? They are paying me. You know, and I mean, and I think that, you know, not to minimize that, right? I mean, I respect all of you in this room, you know, who are here out of civic duty, right? And I'm responsible as a public servant, right, to do my job, right? And so it's not about what, if it was easy, then it would, I'd be the one paying, right? So
I have a comment about the discretionary cuts. So, you know, I'm a school principal, and I think all of our schools benefit from the supports that Communicare shares with us. Any principal that you work with, any wellness team in a school would have data of how helpful their supports have been. The sooner and earlier we intervene with mental health, the better for our community.
I mean, I'm aligned with that, right? I mean, I think that, you know, as I said to the board yesterday, right, you know, everybody in the building is a bunch of bleeding heart social workers and therapists, right? You know what I mean? I was the lead on writing the grant that put the K-12 school partnership together, and that was my project at the very beginning. Like I completely believed in it, right? And there's no good decision here, right? I mean, there just isn't. Except to Jonathan's point that we discover like, wait, you're not performing, right?
I mean, it makes sense to me. I think though that, I mean, again, maybe this is the start of a rubric, but I think measurable results are important, but I also think there's other pieces and the consequences and if there's a way who has to pick it up. I think there's lots of pieces that when you're cutting programs or things, so I just want to make sure that there, you know, is there a rubric or something that is looked at that in totality when we're looking at programs, not, you know, and I think measurable results is a great point, Jonathan, should be a big part of that, but I also think there should be other pieces to that. And I'm assuming there are.
Taking a rubric and some sort of decision making.
Yeah.
I mean, you know, like here in item B here, you can see that there was some, and this wasn't more of a, this wasn't necessarily a rubric, but it was sort of like, okay, principles to guide, kind of guiding the principles, right? I agree with you that whether or not you agree with either of these four, right? I do agree that adding outcomes and the impact of the program is something that should be considered. And I think the board was appropriate in saying that. How many people are being served by each program and how well are these programs performing, right?
Who else could pick up those services if, you know, are there other alternatives? And probably not because there isn't money, but I mean, those are the questions to be asked when you're looking at cutting something. You know, even if they have the data to support that they're doing well, there has to be more than just that as well. There have to be other questions asked as you continue. So we don't need to go in now. I'm just, it's just, I'm assuming that there's a process.
Whatever principles we ultimately land on to guide this decision, right? It is one thing. What I want you to know is that my strategy as the behavioral health director is that we need to generate revenue. I mean, we need to find a way to now there's going to be some things that we do that don't generate revenue and it's just, there's nothing you can do about it, right? So it's like hospitalizations, for example, like for inpatient hospitalizations for adults, right? We can't like generate revenue from that. We just have to pay that, right? So then you start thinking, okay, what can we do upstream interventions, prevent hospitalizations, right? And then have more money that we can leverage to do Medi-Cal billing and other programs. But ultimately, I think that for me, that is the answer. We can draw down federal dollars through Medi-Cal billing. And I don't think that historically we've been very efficient as a system of care, right? We're looking at $25 million of MHSA funding alone, right? And meanwhile, what the information I have is that our entire system of care generates less than $20 million in Medi-Cal billing every year, right? Which would mean we're only leveraging somewhere between $8 to $9 million of the funding available to us to draw down to matching funds. And that's only, and you know, that's the whole system of care versus $25 million in only behavioral health service, mental health service act. So we also have realignment and other funding sources. So to me, I think that there's a lot of missed opportunity in the amount of revenue that we can potentially generate. Now, it's not I'm going to be perfectly honest with you, like it's not my area of like expertise, right? And it's something I'm trying to learn more about, but there's something here around the opportunity to generate that revenue and whether or not we focused on it historically in that and to that degree versus a focus on like standing up programming and things like that, right? And kind of just doing whatever is necessary and not being so focused on the business.
Partners with others that do it very well, right? Or partner with others
right.
who do it very well,
right?
With the Medicare,
right?
With the Medi-Cal, right?
Well, yeah, there's some, yeah.
But I think it is discretionary and both have to be with that. So, yeah.
Agreed. Is there any other questions about my report?
What's the board's preference? Include, a recommendation, do it as is, or do something a little more formal, to make a recommendation? Or
More experience. I mean, I think we've voiced our thoughts. I guess the question is, do we put it in our end?
I think you're looking at the RVAs is because you have someone who's underperforming, should be doing better, or you have a project that has a low percentage of positive results. And sometimes you have programs like that. And you're looking at the RVAs, I think they need to make a distinction between a contractor who's underperforming or a program that just doesn't have good results. Some programs are like that. Kind of my thought on that. If you're gonna look at the RVAs, you have to be able to distinguish between those two in the recommendation to the board, because this could be improved. Program A, program B's outcomes aren't improved, it's actually performing as designed, this has low outcomes.
The benchmarks, I mean, are you looking at benchmarks? You know, this, I think that is part of the recommendation, and where you're going to benchmark too. So I can read it, I think I'm fine with the recommendation. Everybody makes it.
And again, Jonathan makes a point, this board has been looking for outcome measures for a lot of things for years. When I first came on board, there's a lot of talk about that, improving that. And so that's something that should be looked at. If we need to make a formal recommendation, we can do that. Of course, others can do with that what they wish.
Because our direction for this here become more focused on this as well. How do we then?
let me, I just jotted something down, let me just read it to everyone. By the way, I keep asking you all, because I don't, if we want to leave it as is, I'm totally fine with that. Totally fine with that, but this is what I had in mind. HHSA has recommended 4 strategies to prioritize decisions about the MHSA budget for fiscal year 2024-25. The Yolo County Local Behavioral Health Board strongly recommends that HHSA also review the results-based accountability data for each MHSA funded program to help inform them in making decisions about the MHSA budget for fiscal year 24-25.
Promotion for the other side.
Or just, yeah. Motion. Okay. Brandon makes a motion.
I'll second.
A second, any discussion, any changes? I just jotted this down. I took some of that language out of Tony's report, and just added a little bit about, add this to it. Just consider this, all right, all in favor? Aye. Opposed? Abstentions? Okay, passes. So I get that to forward. Thank you, Tony. I appreciate it.
No problem.
Okay, where are we? Let's have some public comment. If there is any. Yes.
So Allison Rodriguez with Community Carol Lay. I mentioned earlier that we hold contracts with our K-12 partnership with Yolo County HHSA, Davis Joint Unified School District, and Yolo County Education. I do support the use of data and outcomes, and we actually really value having data and outcomes to show our progress and how we're serving our clients and how our clients are responding to our services. I would like to encourage that, though, RBAs do have valuable data, we work hard on those and we work hard to, report the data into those. There's so much nuance, and I think a few of you have alluded to that there is data that goes beyond the numbers. So I would just highly encourage that we're not only looking at the numbers that come straight from the RBAs, but we're looking at the quality of data. We have so many success stories and pieces of feedback that we receive on a weekly basis from school staff and our families that we serve, saying that these services are valuable and needed, and Just even the operational piece of it, the way that we're integrated into the school campuses from day to day holds so much value, that you're not going to see in RPA. So, agencies could even have the freedom and flexibility to provide their data on what we think is valuable and what we think is valuable. And of course, have that supported in a collaborative way from our partners and the schools. We would greatly appreciate that inspiration.
And I agree, and thank you for that, and all the reports we've done, especially at the DA's office, we put, what they've asked for, in terms of the objective measures, but we also include, the success stories and photos and all those different things, because those are important too, so, thanks. Anyone else? Jen?
Yeah, Jen Boucher Dancer, NAMI Yolo County. Thank you all for your work here. Thank you to Tony for really taking a difficult job, but taking great accountability with it. So I just want to say off the top that I really appreciate that. NAMI, of course, as everyone in this room is as well, we are worried about what the impact of this budget is going to be on the lives of people in our community. I know that you all are right there with that as well. But it's, it's frightening. Of course, at NAMI, we are also, concerned about what any cuts in our contract would mean for our ability to continue delivering our programs at the current levels, or at all. NAMI Yolo County is very grateful for the county's support in providing MHSA funding that allows us to provide our educational programs and our support groups and our community presentations at no cost to participants. That's also a requirement of being a NAMI affiliate, is that we are not allowed to charge a fee for NAMI signature programs, such as our NAMI Family to Family class or our connection support group for peers. As part of our requirement to be a NAMI affiliate, we must provide those at no cost to our community. And so our MHSA contract provides really critical funding, what has been a stable source of funding for us up until recently. So we certainly recognize the challenges with, I guess, the MHSA budget Tetris game. It's not, as Tony mentioned in the Board of Supervisors meeting yesterday, it's not even just you make it one, you can make one cut here, but one cut is going to, trigger potentially an avalanche of other changes that have to be made. And so the complexity of this is certainly not lost on NAMI, and we, are greatly appreciative for all of the time and efforts that the HHSA staff is putting in to be able to really present good, solid recommendations to the Board of Supervisors. We absolutely recognize that, there's probably no contracts that are going to be unscathed in this next fiscal year's budget. As I think you all probably have experienced as well, the budget situation for the next fiscal year is not something that we all necessarily saw coming 9 months ago, to this degree, at least. And so, cuts for the fiscal year starting in less than a month do become very challenging, not only for NAMI, but for all of the community partners that are funded by HSA. So we are just highlighting the importance of our programs and the impact of our programs. And I shared a little bit in the Board of Supervisors meeting yesterday, but I'll share a few with you here as well. Some of the recent quotes that we have received from people who have participated in our programs and have benefited from them. One person said, "This group and the NAMI organization were a lifesaver for me." Another said, "It has been hard losing out on intensive outpatient, but I'm glad there is a support group that exists that is somewhat similar to that experience." Still another said, "This group has helped me for the past 6+ months because I didn't know where to start. The classes were so informative, so I could have a foundation for what may lie ahead." Another said it's encouraging every day to know NAMI has support groups for so many consumers that are free of charge. That's amazing. And another said that their participation in our support groups provides the opportunity to share with others their situation without judgment and with confidence of confidentiality. So I just wanted to share a little bit of the, some of those impact statements that we have from the benefit of our program. And again, absolutely understand the incredible difficulty with, frankly, not only the MHSA budget, but the entire county budget. And we are just hopeful that the county and the Board of Supervisors are able to find a way to continue.
Thank you, Jen. Anyone on Zoom? All right, seeing none. Thank you, Tony. We will move on to the Board of Supervisors report. Any reports?
Yeah, so I just wanted to introduce Moses, although he's been introduced already. He's our new District 1. So it's just there's a budget hearing next Tuesday. Board is holding general county budget. So I guess the focus is prioritizing management programs. The ultimate goal, right, is we have to have a balanced budget, so looking at maybe potential cuts to discretionary programs, but we don't really know yet exactly what's going to be on the table. And also looking at a long-term goal on the structural deficit. I mean, it's pretty gnarly. It's not, it doesn't look great, but I think the county's going to have to find some creative ways to keep this from happening. Like, can't go into every fiscal year having $30 million budget. That's what it looks like. And I'll pass it to Emily if she has any information.
Thank you. Emily?
Yes, I do. And was that, I don't know, was that Jack speaking?
Yeah.
Okay, I couldn't hear him, so I apologize ahead of time if I'm going to be repeating stuff that he said. So just want to say I appreciate the opportunity to be here tonight. I'm Emily Alt, and I serve as district representative for Supervisor Frericks. Unfortunately, he had a scheduling conflict tonight, but he looks forward to joining you all next month. Supervisor Frericks asked me to share a brief update regarding the county's overall budget and key themes, and some of it will be repetitive from Tony's presentation. Regarding the mental health budget, these conversations are critical as we navigate financial challenges while ensuring our community continues to receive necessary support. As many of you know, Yolo County is facing a significant financial pressures. The general fund was initially forecasting a nearly $40 million structural budget gap for fiscal year 2025-26. To address this challenge, the board will be holding a budget hearing on June 10th, next Tuesday, to consider adopting a balanced 2025-26 recommended budget. This budget closes the gap through a combination of ongoing department identified reductions and approximately $20 million in one-time funding sources and reserves. It's important to note that this budget provides appropriation authority through September, when the final fiscal year 25-26 adopted budget will be considered. As for mental health funding, the June 10th proposal assumes a status quo budget utilizing the full remaining fund balance to sustain services. At the June 3rd Board of Supervisors meeting, the board received an update from Tony regarding the existing deficit in the mental health budget. We also discussed the broader implications of transitioning to the Behavioral Health Services Act, Prop 1. Throughout this discussion, several key themes emerged from the board's deliberations. Number one, preserving fund balance. So given the level of funding shifts anticipated, there's a preference to avoid exhausting the fund balance entirely in the 2025-26 budget. Number two, upcoming considerations. The board will be looking at potential expenditure cuts, not at next week's budget hearing, but in ongoing discussions leading to the September adopted budget hearing. And then number three, long-term strategy. This approach allows additional runway and preserves some fund balance to help address anticipated reductions in the 26-27 budget year. As Tony's report tonight states, during this process, the board affirmed 4 key principles presented by HHA staff to guide decision-making when considering reductions. Number one, focus on funding mandated service levels. Number two, prioritize services for Medi-Cal recipients. Number three, maximize Medi-Cal reimbursements. And number four, reduce spending on discretionary programs. Additionally, the board emphasized the need for a quote unquote scalpel rather than an axe approach, meaning that reductions should be strategic and data driven, as you were talking about tonight, considering measurable outcomes and the number of individuals served. Supervisor Frerichs is particularly interested in hearing the local behavioral health board's perspective on these guiding principles as you shape your upcoming decisions. There's also interest in assessing existing programs currently funded through MHSA that could potentially continue under BHSA, understanding that overall funding availability does remain a concern. Ultimately, the board recognizes that even if all existing expenditures align with BHSA criteria, we're still working within a reality of reduced funding. They're seeking further clarity from staff on strategies to address the mental health structural deficit while ensuring mandated services are met and minimizing harm to vulnerable members of our community. At a time when we should be increasing investment in mental health services, it's undeniably difficult to discuss potential reductions. Supervisor Frerichs has shared that this reality is heartbreaking, and he's committed to ensuring that thoughtful, informed decisions are made. To that end, he welcomes feedback from the local behavioral health board to help inform and advise both county staff and the Board of Supervisors during these deliberations, which you all started tonight or continue tonight. So thank you for your time today, and we do look forward to hearing your thoughts on this critical issue. If you have questions, I'm happy to take them back to Supervisor Frerichs.
All right, thank you, Emily. Okay, criminal justice report.
This is getting harder and harder to do now that I've retired,
Right.
in his office. It used to be, for all the new members, it used to be updated on our specialty courts, our diversion programs as they address mental health issues. But since January, the DA put a hold on people going into specialty courts in order to focus effort on getting a Prop 36 treatment program up. Possibly much too early at, or the numbers are going down. It's unfortunate. Sounds like there may be a reorganization of a couple of those programs, but again, I don't know what's going on with that, so I'm not involved in it. So I'm not sure how much keeping this on the agenda is going to be productive going forward. I missed the number, so I apologize for that. I attended the last opioid coalition meeting. It's a monthly meeting dealing with opioid issues in the community. And there's going to be a fighting fentanyl, a fentanyl awareness event in West Sacramento. Pass some flyers out on June 14th. That's one. I'm sure everyone knew about that. If you have anyone that's interested in it, I'm going to try and catch this and what it's all about. We had a presentation at the opioid coalition meeting in this. So I promised to pass these out. That's all I got.
I have just a question. We pivot, just maybe in having an update, maybe make it an official under the something, because every month we have something on
Opioid coalition.
this. Yeah, like our opioid crisis or something.
So what would it be?
I just volunteered you.
What would what would you call it?
I don't know, I was just thinking, you hear,
He wants to.
it just says like for behavioral health now, right?
I think when we talked about our agenda of presentations,
Right.
I think I put out last time, there's the Addiction 101, that video, how people watch that. That's a really good overview on opioid addiction and medication assisted treatment, how that works. About 25 minutes long, and it's easy to understand. But I think we need to have a public health officer come in and kind of explain what the opioid crisis is, what the fentanyl issues are, what our treatment programs are. I believe some people went and saw Walter's house visit. So getting someone to give a presentation on what is the drug Medi-Cal program, what are the different types of treatment levels or services available in the community. That's a starting point.
So the chair gets to set the agenda.
Yeah.
I
know, I was just, yeah.
So maybe before the next meeting, when we talk about the agenda, we can add an item, and then maybe if we don't have a presentation, maybe at the next meeting we can do something like this.
Just an overview. When Dillon County became a drug Medi-Cal county, that meant that everyone on Medi-Cal could get treatment, and it was based on needs assessment, based on medical necessity, and it could be residential treatment, to intensive outpatient treatment. And so that's available in the community. There's a lot of challenges with having enough residential beds and a long wait to get one of those beds. But that's kind of an overview of what's available as far as what kind of our responsibility for the Medi-Cal folks. And the private pay is a whole different problem. And I've encouraged people to take their kids off of their insurance and put them on Medi-Cal because the services are better in the county to get the treatment services they need, as opposed to going to your primary care physician and being pushed back and all that. So it's interesting conversation. Someone can't believe I'm going to take my kid off my health insurance and put them on Medi-Cal, or some private insurance programs, because they're through a union, don't allow them to take the kids off the program, so then they're not getting the better services. So I think, Tony, you probably got someone at HHSA that could do a presentation, maybe Glenn Johnson or.
Yeah, I mean, I'm happy,
Julie might be able
you
to.
mentioned a public health officer.
Yeah.
I mean, whatever, we can have some.
And what are the different, those vending machines with certain things in them?
I think they're like right next door.
It's right next door, but
Yeah.
you know, how that works, and, you know, including the medication assisted treatments. We didn't used to have that in the jail, but we've got that now. A lot of things over the last 5 years that have really changed as far as what the substance use disorder treatment options for medical health individuals.
All right, well, so we'll work on that for next meeting. And I want to put a bug in your ear, Tony. The Opioid Coalition sent over a draft resolution for, what is it, Opioid Awareness Month in August.
It's International Opioid Awareness Day, August 31st.
And so I spoke to Supervisor Villegas about this because I wanted to run it by him, and maybe he would want to be, whatever you're called, the sponsor of it or whatever. And so I sent it to him, but it's so far in advance. Like, I mean, I sent it because I got it. I wanted it off my plate. I looked at it, sent it to him, and he's got time. And I have little Outlook reminders, but I want to make sure, if you could, that it's on his radar. Doesn't have to do it right now, but start looking at it, you know, in July, so that he can give some feedback on it.
Okay.
So he has that, and if he says to you, oh God, I get so many emails, where is it? I don't have it, just let me know, I'll get you another copy.
I think I wanted to ask this body to make a recommendation
Oh,
for
right.
that at some point, but I think
Yes.
that Jonathan wanted to socialize it with the supervisor too before we did that, as far as.
Thank you. Thank you. So yes, I forgot that. I already forgot that. They wanted a recommendation from this body before I did that. I didn't want to put the cart before the horse, and I wanted to make sure someone on the board looked at it. So there is a little bit of a time constraint on it, because it would be nice if we could look at it at our next meeting, which is the first Wednesday in July. But if you could just take a quick look at it, or, you know, in June, that'd be great. Okay, thank you. Okay, ad hoc committee reports, site visits. Like, this has been pushed off a lot, and I can't remember if we talked about all the site visits that you guys went on. Maybe we did all that, but I felt like I can't remember now. Have we talked about all the ones that we went on?
We definitely talked about Safe Harbor, the other ones.
We haven't done it, yeah, I mean, there hasn't been.
What have we done besides? Because I would like someone, so we had a very, it was kind of an informal, when I say informal, it wasn't really part of this site visit ad hoc, because the woman who used to be our caseworker for addiction intervention court took a job at Walter's house as the program manager, and Chris and I bought a table for the nominating event, and we invited her, and I learned that she was the program manager, and we worked out a tour. And so last Friday, I just kind of called a few people last minute, including someone from the chief deputy, the DA's office, chief probation officer, Sue came, Kimberly came. So I want to, again, that wasn't really part of this site visit ad hoc, but maybe we'll talk a little bit about that. But besides Safe Harbor, were there any site visits that the ad hoc committee?
We did a report last time, Sue and I, on the.
Which was also not under the ad hoc committee, but yeah, we
So so we've done those. Do you want to talk about? No? Okay. I'll just mention really quickly about the visit, and if you want to, either you want to chime in, you can. It's, first off, I, for some reason, thought it was over by HHSA, and I even gave Kimberly the wrong address. Even though I put it correctly in Outlook calendar, she texted me and said, "Where is it?" And I said, "West Beamer," because I just was like, and it's East Beamer, sorry.
Moving around.
Yeah, so she was,
Beamer for
yeah.
like 20 minutes.
So
being
it
like, "Where's-"
ends up that it's way on the outskirts on East Beamer, almost by Poline or 102. And, but it's really incredible. So there's a lot of housing there that is housing for people that are unhoused, like bungalows. But then there's a large building that has, it's state of the art. We saw some of the clients in there in their groups. And it's, you know, things have completely changed in that world compared to just 10 years ago in terms of how these individuals are treated holistically and harm reduction. You know, they expect some missteps, and the women's side and the men's side and the dorms and the medical exam room and the break room, and the kitchen is really incredible, state-of-the-art industrial kitchen. Little exercise areas. They're gonna build, Melinda, the chief deputy in Yola, said she would help them build a pickleball court. We were there, she's like, "You need a pickleball court," because they have this big space. And it was just really, really impressive and really uplifting in light of everything else that's going on, you know, that we're dealing with, you know, in terms of moving forward. I think it was about third full, maybe, something like that, third capacity, because it's so new. It's like so brand new. So that's really exciting. And that is, I would say, dual co-occurring with maybe a greater emphasis on SUD, but it's still co-occurring. They don't dispense medications. I didn't understand the difference between that at first. They just give them the medication, so they don't say, "Take this," they give, "Here are your medications." They keep their medications. When it's time to take them, they give them, you know, the bottle or whatever. And it was just very impressive. And I don't know if you guys have anything to add to that.
Yeah, no, it was very clean, very impressive. The people who worked there seemed very interested in being supported. I thought it was interesting. They also talked about that they're going to be opening a center for pregnant women, so that because there's no place for them in Yolo County right now, so we're going to have something for that, so that they can be treated for addiction while they're pregnant. I was just very impressed.
Yeah, it's just like a very informative kind of visit, because I think seeing the inside of those places is, if you haven't had this experience of that kind of thing, like very useful to kind of see that kind of facility or experience. So yeah, very informative.
Okay, anything else on that? All right. Budget committee, anything on that? Okay. Annual report. So Kimberly, like she said, being a workaholic, a little bit of a workaholic. I think she had 4 meetings with the ad hoc committee. I was at one of them. I couldn't make the other 2, and we were meeting from 4:30 to 6:30 p.m. last Friday night.
And the other 2 meetings worked out that long as well. So we met for a while about this. But anyway, I just wanted to update everyone on progress regarding the annual report. So I kind of reviewed components of example annual reports from other counties, and also the sample outline within the best practices handbook of local behavioral health boards. And then I kind of created like a draft outline of kind of components to include. And I think for purposes of this meeting, it just kind of, I wanted to bring to your attention like a list of compiled potential recommendation topics. So I went and I dug through the minutes from the last year, and I kind of, I guess like highlighted topics that have come up repeatedly or that the public has expressed concern on. And I kind of wanted to just maybe read through potential recommendation topics so I can kind of like consult as a board, like what we want to kind of focus on. So one of the topics is crisis now, and then within that is policy around crisis continuum, receiving chairs, education for public and service providers, and the children's continuum of crisis care. Children's mental health, school-based services, full service partnerships, cooperative mental health court, addressing community stigma, public education, CIT for first responders, NAMI classes, housing and homelessness, coordination between agencies, EMS protocols, public guardian, applying for grant funding, having publicly available data, retention and aging USA, and then substance use services and addiction. So I know that kind of threw a lot of topics, but if anyone kind of wants to add anything or look into or kind of have any thoughts about, I guess like trying to expand on one specific topic, like I want to hear feedback.
I think for the annual report, as far as substance use, I think that maybe next year, because we're just getting our feet wet on this. So I think we need to get a feel for what's out there before we include that in the annual report, because it's been something new as of January, but most people here don't have a lot of experience with it. I'm still trying to get up to speed. But probably would put that'll be important. But let's save it for next year.
Just in terms of timeline, we kind of discussed potential timelines and apparently, for the board of supervisors, it would be most helpful if we kind of have a complete annual report around kind of January, February of next year, because that's prior to when they're making recommendations, that's when an annual report would have the most impact. So that's kind of like our timeline. And then we ideally want to get this complete and approved by the board by December.
By this board.
By this board. By this
Okay,
board.
I'm sorry, I thought we were looking at doing one this summer. But
We were, but during our meeting, we decided to consult with, one of the deputy.
I was under the assumption we were still doing one for this summer.
Yeah,
Yeah.
yeah, and they suggested, because we said, when's the best time? And they said, really like January, February, because that's when the budget's gonna be.
I think we're also looking at these as the areas that we would like the board of supervisors to prioritize. So not so much a report on what we've been doing in these areas as we want to make sure that they're taking these areas seriously. At least that was. Yeah.
Okay, so, and if you have feedback and you want, between this meeting and the next meeting, and you want to just email immediately or. Please.
Send that out.
Yeah.
Yeah, we'll send that out and then you can reply to, do a reply, and if it goes to Christina, she can get it back to the, committee and do it.
And I think from a timeline perspective, just so everybody knows, is that if we're looking at getting it to the board of supervisors in January, we'd be looking to approve it in December here, and we're off in August. So, November. We're off in November, not December. So, it's gonna come around fast, and so, we might be sending things out, and we'll let you know, but we're gonna ask that people, understand that emails might be coming towards the end of the summer, and then if you could read them before the meeting, we're going to discuss them. Is it, we've not really ever.
Okay, bylaws amendment.
All right, so this is pretty straightforward. The idea is that we create another officer position for the past chair. And you can see the exact language that would be, how it would be written into the bylaws here in the agenda. If you haven't had a chance to look it over yet, I don't know if anyone needs a moment to.
All that Alex.
And that's a 1-year position.
It would be, well, that's a good question. I envision it might be more than 1 year if the chair stays on an additional year.
I think you want
So it
to
says, that's why
specify
it
the
says,
term. in
well, I
there.
think it says past.
You could have multiple past chairs.
Well, it doesn't say, you meant to say immediate, we can change it. I thought it
Immediate
said
past.
Immediate past. Does it say immediate? I meant to say immediate.
Doesn't have a meeting.
Additionally,
Oh,
Comma or outgoing.
I was just curious, is that a series of past chairs or the most recent past chair? How are you?
Yeah.
So, yeah, it's just with written.
wait. Oh, the past or outgoing, is that, we need to make it more clear, or is that?
Just
clear?
the outgoing.
Just, yeah,
Oh,
going
oh,
to
oh.
the past, not the past.
Oh, take out the word
Eliminate.
past. Okay. Take out the word past, outgoing chair, and then for the last part, take out the word. The out. Oh, no, this should say well, then, at the very last, there's two parts. How should we word the very last sentence?
Well, I guess one question is, what are we going to call this position? Because maybe that should be
Yeah,
what's in that final sentence. So I was assuming that the actual name would be past chair, but if past is creating problems, then maybe the
we
actual
could
name should
say-
be outgoing chair.
Well, I've seen it in the bylaws as the outgoing, but their title is the past chair, so, but if bylaws specify it's the outgoing,
so we say
but
outgoing.
it's the past chair is their title when they're on the board. That's how I've seen it done.
Okay, so should we say additionally, the outgoing chair, known as the past chair, shall be an officer?
And and then the very last sentence should say past chair.
Yeah.
Okay, because it's.
Although I think I would capitalize.
Okay, great. All right, any discussion on that? Okay,
Do we have a motion?
I'll second.
okay, Stephanie and Chris. All in favor, say aye. Opposed? Abstentions, passes. I'm going to appoint the ad hoc bylaws committee to write that up. Can you do that soon?
Sure.
Can you amend the button? And what did they, last time we did those? Wondering if we even,
Oh, do we have to vote on the bylaws again?
well, no, I think we just did.
Oh, okay, so
This is
we're
a
We
good.
just voted to amend them.
Yeah,
Yeah,
but
okay.
did we, and this might be on me, did we do anything when we did all those amendments? No,
vote on it.
We
No,
voted.
we did.
Yeah, but did it go
But did
anywhere?
we, because it's got it, we submit those to you, or they, you
I
know,
believe it's posted in the website that I can run.
okay,
So we would need to.
I mean, but does that need to go to, like, county council? I mean, are they kept, you know?
I mean, that's the first time we did it since I
Okay.
sat as the
Well,
liaison.
once we get that done, we'll give them to you, and then maybe we can ask if they need to go somewhere with county admin. I don't know if they do or not. Okay.
I'll reach out and ask.
What's that?
I'll reach out and
Thank you. All right, so long-range planning, I don't think we have anything on that, but I promise to be involved in that, and help you with that, as you take on your role as chair.
Yeah, we keep saying that we're gonna bring the proposed topics and have people suggest other topics.
Yeah, so.
Should we do that today or should we?
Do we have a list?
Do we have?
Well, it linked to it. We don't have it in our packet.
Oh.
So you got
Can
it when
we-
it was handed out. I don't know. We have time to do.
Are you taking suggestions now to consider?
Mhm.
I would like to get a presentation on harm reduction. What is harm reduction? What is a negative connotations to that phrase as far as treatment and what it all means. So I think we need to understand what harm reduction is. That's a big part of what Medicare and other programs do. I would like to get a block instruction on Medi-Cal reimbursement, how that works. There's a simple way of doing that, but just because we all the budget recommendations, we do care about leveraging Medi-Cal. I think one of the challenges with previous CEOs, they weren't properly leveraging Medi-Cal, so then we're not getting the best benefit of providing as much services as we can. As a Chris mentioned, the drug Medi-Cal continuum of services, what's available in the county.
Chris, at one point you had talked about ECT and that's not on the list. You want to?
I'm open to that, and that was possibly a joint presentation with the health board, when it's a medical issues here. That was something that could be worked out, so we did have a joint meeting last year, I don't want to do that again this year. Or that could be a topic presentation.
That's when you whether understanding that you can help. Protocol. So I don't know, but it would be, I don't know if you want that as a topic. Presentation, to understand what that is.
Yeah.
We now, with the change with Prop 1, we do have open education membership. And I'd like to know what are the programs in schools or mental health, get a better feel for that. I don't understand that. I had my son had mental health issues that came up with TBI when he was in school. I wasn't real pleased with the way that was handled. I'd like to see what's going on.
Do you have a connection or anybody?
We have some people that have some connections.
There's something to present to this board.
Around school-based programs or whatnot out there for.
I mean, mine would be focused on both ends, so it wouldn't be both.
But is there, are they all different for each district, or is there an overview? Do you have a county office of education? Do they manage any of these things, or?
County office probably could, but yeah, every district wants to.
Yeah, okay.
And uses like Davis uses Premier, so we all use different providers.
It all probably, I'm sure, come up with our own, what we do.
Yeah.
Right, and then put it all together.
I wonder if it's a grid, so we can understand what we're available by.
Oh, okay. I don't have it pulled up over here. I have to pull it up in here. Oh, no, I can get to it. I just.
Want me to just email it to you?
So we could have someone from the county and then we could probably, three of us could probably highlight specific things within.
We have Davis, Yellow, and Sparta.
Yeah. Davis Woodland.
Davis Woodland.
I don't know who would be able to do this, but could we potentially expand that and see what the university coming to?
Yeah, I was also trying to bring up, I think a topic that should be looked into is collaborate with the county and providing mental health care. Because anecdotally, like a lot of the people being served in local crisis services in Davis are like students. And so there's like a whole, like, I guess like in the kind of gaps between like these different systems, there's kind of maybe some information being lost.
I would like to propose a topic, because I'm not clear on what RVAs are. So especially if we're going to be making a recommendation to the board of directors.
Yeah, definitely a topic I want to emphasize is practice now and like development of all components of that system. Oh, there it is.
Thanks, Tony. Thanks, Christine.
Yeah, crisis now and consumer perspective.
And not to, oh, it's up here.
There we go.
All right.
I'm super blind.
SB 43 is good, especially since, what's the implementation date? January. Sorry, Tony.
January 1st. That's what we got when this January rolled around, and SB 43 is our #1 priority. You know?
I'd like to add to the report. I'd like to get updates on how that's panning out.
I would like to also explore maybe how we structure this. There's a lot of great comments. So when you look at how some of the best practices are, I know I don't want to go back to, do we have ad hoc or do we have special committees and then we have to just Brown Act and all that. That's not what I'm suggesting, but liaisons and maybe some of this that we're talking about, do we have liaisons that report out on certain topics, maybe on cadence? Maybe there's a liaison with school, maybe there's a liaison that And these are people that have either information or passion, and then there's report outs as well. So there's the understanding, kind of the education piece of what is it, but then how do we get updates on what's really happening? And so I'd like to kind of explore maybe how we can structure the committee maybe to help support more information coming through, maybe at a faster cadence, but not necessarily always having to be a report out or someone coming to speak to us. We have information, kind of what Chris does, and he's kind of best practice to me. Anytime he brings stuff and, you know, so I don't know if there's an appetite for that, but
I think it's good. I mean, I think maybe it's just formalizing the win member announcements, because we haven't really talked about what that could be.
yeah.
It's really happening anymore.
There's a lot of great topics here, and I don't know if we get to them all.
Yeah.
And so how can we facilitate that? And so a lot of the, and I don't know if anybody, I know Kimberly brought these notebooks, but there's a lot of great information in this, just even around how behavioral health boards are structured, and it's very different, and how these can be done. So I don't know how many we received, or if we can get more.
I got like 5, and they're pretty much gone. Like,
But I'm wondering if she would give us an online.
I think there is an online on the, if you go to the California Association of Local Behavioral Health Boards, but it's such a,
It's on there.
it's such a long name. But yeah, if you dig through that website, there's a lot of really,
Yeah.
compelling resources.
Yeah, it talks about the difference between ad hoc liaison, talks about different ways.
I could send a direct link, because I'm
Yeah.
pretty sure I can find it on that website, I can send a direct link.
Yeah. Is it, and then maybe we can, so people have a sense of what other boards are doing and how they're tackling.
This is usually the link that I send out when you join the board
So
or when you
This is the
become a
best
member.
practices handbook.
Yeah.
Yeah, basically does, yeah.
Oh, so you choose.
I haven't.
So you don't-
Yeah, I try to send it out to them when they start on.
Oh, I see, okay.
To include that link, kind of all, monthly.
I will, yes,
if they have it,
I
so
can
we-
do that.
So we all have it,
Yeah.
because there's a lot of training for
Yeah.
videos
I
and
can do that.
for new members, or refresher training for some of us too.
Yeah, and I would recommend to new members, if you have the opportunity to go to one of the, LPH, like, kind of state trainings, definitely go, because I went and I learned a lot for taking there. And then it's also really good for networking with other local behavioral health boards and see like where their best practices, what are issues they're encountering in their own county, is there overlap with ours, are there solutions that they found there that we can potentially like use here, so yeah, just highly recommend.
And I'm on their advisory board, and sometimes they'll pay for us, one or more of us to go travel and be in a hotel. Yeah, if you guys are interested.
I also think as a refresher, it's really helpful, because when I did that class, it was really new. And not everything like, so works at the same time, so like our refresher is really good too. Or the new, you know, what we need for.
All right,
And then earlier you mentioned like certain months that we don't meet, which months do we not have this meeting?
Typically August and November.
Honestly,
I wanted to ask about that because our next meeting is July 2nd, which is awfully close to July 4th. And last year we had to.
I think it's the
push it
3rd,
back.
actually.
Oh, well, we had to push it back to August last year because nobody was gonna be able to be here.
Right.
So should we be talking about?
I
pushing
think
it
that's a good call out. Usually when it's that close to a holiday, it makes it harder.
That's what your schedule.
My schedule is your schedule.
you want to push July to August? Okay, we'll push July to August.
Okay.
All right,
So we're gonna make our board break in July.
July.
Okay.
Anything else?
Just, is there something that you would want from me, like, just to receive, even if they're not having a meeting? Because I know there's sometimes you guys want updates on different things or whatever, you know?
I guess if there's a, the monthly report you give, there's something that's really important for us to be aware of.
I mean, I'm saying I'm willing to provide a report if even if we're not meeting, if you think that would be helpful.
I mean,
Or is that correspondence that we
I would-
receive?
like, if people are gonna read it.
Yeah.
You know, like, I don't want you to spin your
Okay.
wheels.
All right.
No, I don't think we can do that without being public, can you? We
Um,
have to post it, no?
It does have to be posted publicly.
Yeah.
well, we can post it.
Your call.
Did post it to the website.
Yeah, it's more like a brief by exception as opposed to what you would do. That's something that's really important.
Yeah, why don't you just make it, yeah, I mean, if you want to have the same topics, you can.
Okay.
And that's not, but if you just really make it simple unless there's something.
I think if you share information, but you don't ask questions that would need to be heard by the public, you're able to share that document amongst, as long as it doesn't come from one person to everyone and it comes from me or Tony. Then it doesn't have to be. But if you start asking questions and create a meeting out of it, then we have to.
Well,
publicly post
yeah,
it.
I mean, we can't communicate.
It can be
But
informational.
it can be something that comes from staff to all of us.
And we could ask questions about it in August.
Yes.
Okay.
Okay,
All right.
thank you, Tony. All right, any,
Actually, I got one alibi. As far as the planning for topics, we do have, is it okay if we ask any people in the audience if they have a suggested topic that we aren't aware of?
yeah, I'm gonna do public comment, so if they have suggested topics,
Yes.
and anything else you want to talk about, public comment, 2 minutes.
Oh, okay, let me go back. So one suggestion on topics, when you are looking at, school-based services and looking at UC Davis, I would encourage you to look at all of the institutes of higher education in York County, because there's more than just UC Davis. Jen Bush answered on me, York County, for the record. I also wanted to share that, NAMI California is organizing an advocacy day at the Capitol on June 17th that I will be attending. They'll have some topics that we'll be discussing with, our legislators, but if anyone from this board has anything that they would like me to, bring to that day, please feel free to let me know. I imagine Kimberly has a long list. Please feel free to share that with me, and I'm happy to pass it along. June 17th. I also just wanted to reiterate, it was in Tony's mental behavioral health director's report that we will be hosting a town hall on Monday, June 9th at 11:30 on the grant proposal for Prop 47, where HHSA will be giving a presentation and taking any feedback from community members. And then I also just wanted to share that Hope Cooperative has asked NAMI to come to a resource fair that they're holding on June 18th for their clients that are transitioning out, and asking us to come and provide information on what resources NAMI has available. We are hoping to be able to attend that, but we're still trying to work out staffing.
Thank you.
Alison Rodriguez with Community Relay. In light of Pride Month, I think it would be great to have some information on what LGBT plus services we have available in all of York County, and just further the efforts to make that cohesive. I think that different groups are working somewhat siloed right now to meet the needs of LGBTQ plus, and we do have a lot of things out there and resources available, so it'd be good to just get that all together and talk about it here. And we have our 5th annual Pride Parade coming up in Woodland. We're so excited. If you haven't been to one, this year is the year to come out. You can have a float. You can sign up, have a float. You can also just join with a group of people and be in the parade and walk alongside everybody. We'll have an after party over by Woodland United Methodist Church, and we haven't promoted it too much yet because we had our flyers out, but we're gonna have a drag queen show this year, so it's gonna be wonderful. And we'll have food vendors. What day are you holding that? Oh, sorry, June 21st, starts at 10 a.m. downtown Main Street.
Thank you. Okay, anyone who's on Zoom, public comment? All right, anything else? Okay, we are adjourned.